Yeah, I mean, I think all patients, as individuals, can have their unique and sometimes limiting toxicities to individual agents. There are some toxicities which are fairly predictable and often mild, and things that patients can be supported through. But occasionally, we get generally less common side effects that really require changes in treatment. This was during the meeting a case where it's a patient who, although he had a history of almost 35 years, over that period of time, his management had been difficult because he developed intolerance to a number of medications, including interferons and hydroxyurea, and eventually progressed on ruxolitinib. And I think the other part of that message was that clinical trials are an option for some patients, and they're always something to be considered. And the other half is of the story is in patients who are progressing, that bone marrow transplant should always be considered as a therapeutic avenue, and that the consideration of transplant necessarily involves two things: the availability of a donor. You can't talk about transplant if there isn't a donor available for the patient, and also patient acceptance. And this is an area in the field that is difficult because of the high toxicity and potential mortality associated with transplant in the short term, but in the long term, its potential to cure these diseases. And so it's a matter of when is the right time, and everybody agrees that it shouldn't be done too late and it shouldn't be done too early, but nobody can agree what either one of those terms means. And so we're kind of left with the conversation as this is the only curative therapy, but it is one where the timing has to kind of feel right to the patient, and a donor has to be available.